Chapter 1, Lecture 3, Pulse of the Health Economy. In previous section, we talked about the four basic questions that economists try to answer about the production, distribution, and consumption of goods and services. In this section, we talk about the three performance indicators of medical care, which are cost, access, and quality of care. Now, sometimes we call them triple aim because we are by any introduction of any new policy or intervention or any new technology, we are targeting these triple aims. We are targeting to decrease the cost of healthcare. We are targeting to aiming to increase the access to care, and we are aiming to increase the quality of care. So the point here is that there is a problem here. It is not easy to aim all of them at the same time. So that's why sometimes we call them the iron triangle, because there is a trade-off among this three-legged stool of medical care. So any new policy, any new intervention, any new health technology, basically aiming these triple aims, and by aiming one of them, sometimes we have to sacrifice the other two. For example, the introduction of Affordable Care Act was basically the main objective was increasing the access to healthcare for everybody, universal healthcare, basically insurance for everybody. So the preference of the previous government was increasing the access to care. So definitely everybody know that at the beginning, at least, by increasing the access to care, we end up to increasing the healthcare cost, at least for the first few years. So the plan was, by increasing the access to care, then everybody can have a routine healthcare. So by having the primary care doctor to go to doctor and take their prescription medicine and everything, so to keep control their chronic diseases. So now these at the beginning, at least for the first few years, increase the medical expenditure, especially keeping the as you know, there is just a small percentage of the people with multiple chronic diseases. They are utilizing the majority, higher percentage of the healthcare resources. So if we keep them basically under the universal health care plan and give them the access to care, so definitely keeping those elderly and those with multiple chronic diseases under control would be very costly. So so that's basically, depends on the preference of the society and the government on the power, which one to choose, whether they care about giving the primary human right access to healthcare to everybody, or like the preferences of the current government is decreasing the cost, even if it's in the cost of basically a few million people to lose their access to care. So that's actually the cost of decreasing the healthcare costs with the new healthcare plan. If they finally decide to repeal and replace the Affordable Care Act with a new healthcare plan, so basically the plan is aiming, decreasing the healthcare costs. So the same thing for quality of care. If we increase the quality of care by increasing the number of the by increasing the number of the physicians and nurses, by increasing the number of the hospital and uh, basically the machines. So definitely that um, increase the cost. There is a trade-off, and we have to, the society and government and the power have to make a decision. Um, what are their preferences, to aiming any of these triple aim. Um, Now, what is the definition of medical care cost? Medical care cost represents the total opportunity cost when using various societal resources to produce medical care. So we talk about the definition of opportunity cost is the next best basic choices that you have to give up by choosing the first one. So if you choose to use basically your resources in healthcare, then you are basically giving up to use those resources in other industries, such as say that education, recreational, basically industry and defense industry, so and etc. Um, so the so the Center for Medicare and Medicaid Services, we call CMS, collect since 1960s collects and reports data on the utilization and cost of medical care during the past few decades. So these data um, are very important and can give us actually very important insights on the utilization of healthcare funds, their sources, where the money comes from, and the actual amount spent on medical care, where the money comes from, and where actually the money goes and is spent, basically, where we spend the resources. Um, now, so again, why these CMS data are very important? Because based on those four questions we talked about, we wanted to know whether really this medical expenditure in the United States during the past few decades have been increased more than the increase in the other goods and services in the other industries. Because over the past few years, you know that because of the inflation and all the other factors such as new technology, definitely everything have been increased. The cost of everything in all the industries have been increased. So just just pointing out that the healthcare costs have been increased over the past few decades doesn't make any sense unless you compare to the cost of the other products in the other industries. One, the second, you have to compare these costs to the healthcare costs in the other countries. So so that actually, in that way, we can make a conclusion whether the medical care costs increase over the past few decades was unreasonably higher than the increase in the cost in the other products and services in other industries, and whether our medical care costs in the United States are more expensive than the costs in the other countries. So let's see, based on the CMS data, what are the sources of medical funds? So where the money comes from, basically. From mid-1960, by the introduction of the public health insurance programs via Medicare and Medicaid, so basically the government increased the coverage of the elderly, those over this age of 60, and those with the lower income under the Medicaid. Um, so, what about the private insurance? Um, so the fund is spent on national health um, basically decreased from the private sector from 76% in 1960 to 53% in 2010. So previously, before the introduction of CMS, Medicare and Medicaid, most of the people, when they were going to the doctor, they had to pay out of their pocket. Um, and so only the insurance was basically for hospital stay. But currently, the insurance companies they're increasing their coverage from hospital to inpatient, outpatient, and even more to the dental and vision care and etc. Um, So this graph is a good graph to show us the nation's healthcare basically expenditure, where the money came from. Um, so of course the money came from people and government, and basically if we look at this graph in the left, we can see that the Medicare and Medicaid are the major payer, and of course the other government program altogether. Um, then we have this private insurance, which are basically one third, it's covering one third of the total. And then we have this other private, and then we have the out of pocket, which is about like 12%. So altogether, we can say that government is responsible nearly about 60% of all healthcare costs, and so it depends on what year of the data you're looking at. This is 2012, but in a newer actually data set, usually the data shows government is responsible for financing nearly 60% of all healthcare costs. Um, and so in this graph, this in the year of 2012, CMS only accounts for direct payment from government, which basically accounts for all these three are going to be about like 51.6%. Now, so the direct spending of government is about 45%, but then there are public employees benefit 5 to 6%, and then tax subsidies for health insurance premium 9% or more, which actually it comes to about like 60%. But remember, CMS does not include the other employees benefit source of medical funds. So we have employees actually insurance and private health insurance. Now, so we talked about those in more detail. But when just here, I wanted to make your attention to the point that when we are talking about the out-of-pocket payment is about like 12%. This is direct pay, means that at the time of the service, you really pay out of your pocket. Otherwise, all of basically everything is coming out of your pocket, from taxes, from premiums, from foregone wages, basically. But this is very directly out of your pocket. So this is very good actually graph to say where the money, the funds are, coming from, at least in 2012, and where it went. So this figure shows that the hospital services are the most expensive care in almost basically in all the chronic diseases. Hospital care is the biggest percentage of the cost. It accounts for the biggest percentage of the um, cost in all the chronic diseases. Now, the second major expenditure is physician services by 20.2%, which makes sense because um, doctors are gatekeepers, and all the patients first have to pass through the doctors to get prescription drugs and etc. Basically. Now, so since 2010, and basically after 2010, we can say that these two categories accounts for 50%, more than 50% of total expenditure. So if we wanted to target the cost, if in triple aim, if we want to target to decrease the cost, we have to decrease the hospital cost. That's what is the plan with the CMS, to decrease the probability of patient to end up to the hospital by keeping under control the patients with multiple chronic disease under control by regular routine care, and also decreasing the length of stay. So remember, there are two cases: decreasing the probability of going to the hospital, and decreasing the number of the basically length of stay in the hospital. So any intervention, any policy, any technology is basically targeting to decrease the length of stay to hospital. So to decrease the length of stay in hospital and decrease the probability of going to the hospital, you have to increase the physician services to control those a small percentage of the people, elderly and those with multiple chronic diseases, that they are basically using most of these services. We have to keep them under control, their chronic diseases under control, to decrease the cost. So let's look at the total health expenditures. So we have heard a lot that the total health expenditure have increased substantially over the past several decades. So looking at this graph, we see that the healthcare expenditure increased from 74.6 billion to 3.2 trillion. Now, so the trick is that we have to basically take into account the inflation. So even by taking into account the inflation here in constant dollar value in 2015, the health expenditure in 1970 was 365.8 billion compared to the 3.2 trillion in 2015. So definitely there has been significantly increase in the healthcare expenditure. But this doesn't make any sense because we have to compare this cost over the past few decades compared to the other basically goods and services in other industries, right? And doesn't make any sense because definitely, your income also increased, although we actually adjusted that here, but definitely people a standard of living have been improved over the past few decades. So unless you compare it with the other goods and services and with the other countries, it doesn't make any sense. So let's see. So amount of medical care spending, maybe there have been a greater productive capacity over the over the past few decades. So maybe we had a improve in productivity of the healthcare over the past few decades. So maybe there was a shift in the production possibility curve to the right by more labor and capital resources. So which is the good thing. So therefore, by improving the production possibility curve, by shifting the production possibility curve to the right, so definitely increasing the cost, it's not a bad thing. So more of a one good or service that can be produced without sacrificing the other. So by shifting, parallel, basically shifting means that more of goods and services in both nursing home and the maternity basically services. So we are not sacrificing one of the services in the previous graph that we had. Now, to actually make it easier to compare, then let's divide this amount of healthcare spending by GDP. So we have to compare by our national income, and then we have to compare actually per capita to make more sense. So when we are actually dividing per capita, per population, we see that the healthcare costs increased from $1,742 per capita in constant 2015 dollar to close to 10,000 per capita in 2015. So basically, the increase in healthcare expenditure per capita is very actually significant here. Again, doesn't make any sense unless we compare with the other costs. So the costs of healthcare are high and continuously rising, and we saw that basically increased to more than close to the 10,000 per capita in 2015. In here, this is in 2010. It was 8,400 per person. Comparing to $26.9 billion and $141 respectively in the 1960s. So I have basically different years of the cost to show you how basically the healthcare costs change over the years. So the trade-offs maybe involved high healthcare costs, lower amount of other goods and produced and consumed. So let's see if we can actually look at the healthcare costs compared to the national income over the years. We can then compare basically the healthcare costs with the other costs in the other industry as well. So we are looking at the percentage of the national income, GDP. Healthcare costs accounted for about 7% of the national income in the 1960s compared to the 18% of the national income GDP in 2015. So definitely healthcare costs have been increased more than the costs of in other industries over the past few decades. So in summary, let's see the underlying forces for increasing demand and the cost in the medical sector. So let's just pay attention. We are dealing with the aging population. About 14% of the population use 36% of all hospital stays. So this is something we have to take into account. Keeping the people alive is costly. So it's not a bad thing, right? This is a good thing. That's a positive point. Technological advances that enable early diagnosis. So therefore, the people again live longer by early diagnosis. So instead of diagnosing a patient with cancer in stage 5 and 6, that basically they die we diagnose the cancer in earlier stage, in the stage 1 and 2, so we can actually treat them. It's costly. It's costly, but it's a positive, actually, it's a positive thing. A new method of treatment, again, keeps people, longer alive, so it increases the quality and quantity of life. Need for more highly trained medical personnel, so the doctors and nurses and physician assistant and nurse aide, all of them are actually more educated, which is a good thing. Increasing wage rates, basically, because we wanted to attract more nurses and technician, and of course we want to those with the higher qualification to kind of take these jobs in healthcare. So therefore, we have to give them a higher wage rate. The introduction of Affordable Care Act definitely increased the healthcare costs over the past few years. The first step was to reduce the number of the uninsured, so definitely giving access to everybody. We have to spend some government funding. The developing shortage of physician. So while we are trying to attract people in medical, basically personnel, the criteria for accepting the students in medical schools is very high compared to the other European countries and developed countries. Basically, the criteria in the United States is very difficult to pass. So therefore, we have a shortage in physicians because the United States always wanted to keep the quality of the filtering very restricted and difficult for passing the physicians, basically a student in medical school. The number of the admission is very short compared to what we need. Even for those immigrant physicians are immigrating to the United States, the exam they have to pass is very difficult and basically compared to the other European countries, the admission, the exam for healthcare basically personnel passing the exams are much easier in the European countries compared to the passing the exam in the United States. So this shortage, so it's basically is another thing in the United States, keeping our physicians, number of the physicians we need less than what basically we have. So that's actually another reason. Maybe we have a medical error. That's one of the reason for basically shortage, increasing the medical errors. That we are going to talk about that as the consequences of a shortage of physicians. And then we talked about the innovative approach to reducing the healthcare costs. They are more likely to be expensive, but at the same time, they are increasing the quality of care and also increasing the quantity of life, decreasing the mortality rate, and so those are basically advantage. They're a positive side and not negative. Now let's move to the access. So we talked about the cost, the access. There are 5 A's of access. There are 5 dimensions of access as defined by Penchowski and Thomas. Now, access to care is fit between the system and the individual within the dimension of 5 A's. their accessibility, acceptability, accommodation, affordability, and availability. From all these 5 A's, the affordability is the most important one based on the researchers actually uh, previous researchers' results. So, how we can actually take care of that affordability by access to care by providing universal insurance for everybody. So, in the United States, the affordability is more important, actually, case for access to the healthcare, medical care. So when we are talking about medical care access, the question is, does everybody have reasonable access to medical care on a timely basis? So timely access is often measured by a percentage of the individuals with health insurance. So again, when we are talking about a new healthcare plan to replace the Affordable Care Act, the first thing we have to look at is how many people are covered by insurance under the new plan compared to the Affordable Care Act. So we know that in basic presentation, the new plan definitely under the new plan, definitely a few million people they lose their access to health insurance. So insurance is very important because it provides access to high cost and their life-saving intervention for a small premium. So when you're paying your monthly premium or whatever, basically annual, depends on what type of insurance you have. So this is basically giving you the peace of mind to cover your medical expenses in the case of the catastrophic, you know, accident, medical emergency that you cannot afford at the time to pay out of your pocket. Now, the health insurance product before the 1970s, most people purchased their health insurance basically just for hospital before 1970s. But after the 1970s, people they prefer to have insurance for the medical care, for inpatient, outpatient, as well as for dental care, for vision, and etc. If we wanted to look at the access, in overall in the total United States population, let's start with the population of United States, which about around 324 million in 2016. So out of this number, the private health insurance through the employer sponsor insurance covered about 160 million. These are non-elderly, they're working, and their dependents basically. And the individually purchased coverage was about like 33 million. Now, the public provided by government to certain qualifying, group of elderly, disabled, and low income. So by Medicare and Medicaid, basically covered 55 million for Medicare and 72.5 million for Medicaid. So Medicare and Medicaid covered over 1 out of every 3 American people in 2016. So 1/3 of the people are under Medicare and Medicaid. Now, if we look at the percentage of the U.S. population without health insurance from 1940s to 2010, we see that the percentage definitely been decreased from 90% in 1940 to about 17% in 2010, and after that, due to the introduction of the Affordable Care Act, that increased even to 7 and 8%, but with the repeal and replacement of Affordable Care Act, we are actually estimating to go up again. So we talked about the cost and access. Let's talk about the medical care quality. The measure of medical care quality, it's very actually difficult. It's not as straightforward. Sometimes it's very subjective. So that's why the best measure of the medical care quality internationally is using the infant mortality rate, which is the number of the children below 1 year of age that died as a percentage of all live births in that same year. So infant mortality rate has improved significantly over the past few decades in the United States. So we can see that it decreased from basically higher than 26.7 infant per 1,000 in 1960s, decreased to 6.7 basically babies, infant mortality in 2009. Definitely, there is a significant improvement of decreasing the mortality rate of the infant over the past few decades. It sounds good, but again, remember, in economics, only relative numbers matter. Relative prices and relative number of the people are cured, and relative mortality rates are matter. How do we have to compare these numbers? We have to do the cross-country comparison, and when we look at the cross-country comparison, we see that this decrease was significantly less than the decrease in the other European and developed countries. So again, this means that the quality of care has not been improved as much as in other developed countries. So also, when we are looking at we wanted to compare the quality of care, we have to look at the system structure and performance. When we are talking about the system structure, it means that you're looking at the ways in which various organizations are designed in terms of their size and scope. So we are looking at the mix of market activities and government. Remember the extreme side of pure market economy and central system. So you have to look at to see the involvement of each of these, government and private sectors in the healthcare system. What is the percentage of the involvement from these both sides, from the government and from the private sectors, and we have to look at the financing and reimbursement mechanism. All this system structure helps to establish the prevailing incentives in a health economy. For example, in the United States, we have a mixed economy of the private and public sector. So we have so many types of insurance, and each of these insurance company, they are basically bargaining with the hospitals. When a patient goes to the hospital, they have different actual prices, depends on what type of insurance they have. So the financing and reimbursement mechanism is so complicated in the United States, depends on type of the insurance you have, depends on the states you live. That makes very complicated. And also basically depends on the, the government's and the power basically of the powerful people. The current government is on the power basically that influence the organization government itself. So this is the picture, the whole picture of the United States healthcare system. Yes, United States favors market system approach to distribute the resources. But the point here is that we have a fragmented system consisting of several subsystems of care. We have, so regarding the financing mechanism, we have to answer the question who pays to whom, how they pay. So it means that how they pay, do they have to pay by, basically by out of pocket, or do they have the premium? So do they have insurance, private insurance covers part of that, how much they pay and what they pay for. All of these are different, depends on the type of insurance that people have. If they have Medicaid for elderly and disabled, if they have Medicaid for poor, if they are veterans, so they have a specific insurance, and if they have private insurance, is different than individual that they are paying, out of their pocket. So all these questions are answered differently, depends on the type of insurance that people have. The financial mechanism is so complicated. The delivery is also complicated as well, because so depends on the basically type of insurance you have, depends on where you live, what state you live, and of course what government is under the power. So then that delivery is different. What care is provided? Do we have to provide only the treatment, or the prevention in also is included? For example, Affordable Care Act was trying to make the prevention so free for everybody, so everybody could have a routine free checkup, basically. And that was the plan was increasing the prevention and decreasing the over the years the treatment. So what care is provided to whom and by who? Again, that's so different. Depends on the private and public providers. The coverage are different, and also the regulation. Who sets the rule and what rules do they set? Depends on the public and private organization. They set the rules, of course. Government set the rules for the Medicare and Medicaid, and then of course the private organization set the rules for the private insurance, but all of them are varies across the geographies and population. Depends on the state you live, depends on the age of the population, and of course so depends on, of course, also by gender and age. So if you wanted to actually again look at the quality of care, we usually, this graph is a good picture showing the structure, performance, and policy. So we said that depends on what structure we have in the country, the organization, market. Do we have the market actually market country that it has a market system, or we have a central system that is actually covered, governed by the government, set the laws and regulation and everything, which we explained. We have a mixed actually market and government country, and each of these, they provide the basically impact the people's behavior. Depends on the type of insurance. Definitely people decide, work. For example, some people basically work because they need insurance. For example, I know a couple that the husband is over 65 years old and is qualified for Medicare, but the wife of that doctor, who's basically, by the way, is a doctor, but the wife of that doctor, who is over 65 years old, is younger than 65, is not qualified for Medicare. So that doctors should work because his wife is dependent on him. His wife had a cancer and is under basically treatment, and the doctor also, although is qualified for Medicare, has to work to have the insurance under his employer to cover his wife. So you see, in the United States, the insurance actually impact everybody's work consumption and even saving. So the pricing premium of the insurance also impact the behavior of organization and market, and also the behavior of the government basically depends on who is on the power, affect the performance of the healthcare, which remember there is a trade-off between efficiency and equity. If you wanted to have efficiency, everybody has to work and pay for their own healthcare. But so then, therefore, we are performing on the production possibility curve. So we don't have any idle resources to perform under the production possibility curve. But then, what about those people that can't work, those elderly and those basically low income, those people, they are, unable, they are disabled to work. So if we wanted to basically consider the equity, then definitely that actually gives the incentives to some people. Some other people, they can work, but they don't want it to work because they have free health insurance and free social welfare. And the regulation basically is affecting the structure and performance and policy. So there's so actually so much relationship between all the structure, performance, and policy that we have to consider. So this is very big picture. We are going to go through the detail step by step later. So I'm going very fast, I know. So Affordable Care Act contains many components such as patient protection and Affordable Care Act and Affordable Care after 2010, which contains many components that should monumentally alter the financing, reimbursement, and delivery of healthcare in the U.S. So it's a big, huge, actually, draft. If any of you have not seen the Affordable Care Act, I will save a PDF form in our file folder. So at this time, as you know, it is unclear if the U.S. Supreme Court basically will uphold or repeal this new healthcare system legislation. In summary, Triple Aim evaluate the performance of our healthcare system based on what we saw in this very brief lesson regarding the access. We have uneven and on average low given, no universal system of health insurance at this time. There are several dimensions of access, but the main point is basically cost, affordability for access to care. So we have 5 dimensions, but the most important one is the affordability to access the care. The quality of care, on average, we have poor quality of care compared to the other countries. We will do the cross-country comparison. As usually we compare through the structure, process, and outcomes, and the cost, the high level and high growth over the time. Cost of care in the United States is very clear, and we do again the cross-country comparison to compare to the other countries as well. This is the end of chapter 1.